morning students. So we will start with community chapter 6. Now it is for both the BSc as well as for GNM. So here mainly we will be dealing about various programs which has been undertaken by the Indian government in order to eradicate certain diseases. So like malaria, filaria, okay, dengue. So according to your syllabus it will be DENT. Okay, so tuberculosis, whatever, okay, according to your syllabus, whatever portions have been given, so that will be covered. So today we will be starting about regarding National Anti-Malarial Program. So here if you see the burden of disease, so during 2017, it is said that total case of about 8,42,095 cases were detected, out of which 104 deaths were reported by the National Vector-Borne Disease Control Program, then WHO. In its 2017 global reported cited an estimated 13.1 million cases and 23,990 malarial deaths in India for the same year. Today when we see, now if you say which is the most infectious disease, it is the COVID-19. All are worried about it, all are scared, right? Social distancing, wearing a mask, using hand sanitizer, hand washing. So we know that it is a pandemic all over the world. It has been spread, and the piteous thing that is still now we are not able to find out the vaccine. Yes, many scientists from different countries, they are coming up with their own kind of vaccine, but it is not yet approved for humans. So likewise in the year 2017, okay, so in the earlier days when you see malaria being a communicable disease, which is again caused because of the mosquito, right? So there were a lot of cases that was reported, and in India the estimation is given, right? So many deaths were very prevalent. So that gave a rise of detecting this or bringing into existence of this program. So nearly 70% of malarial cases in India are contributed by 5 out of 36 states and union territories. So at least 5 cases were reported in each 36 states and union territories. These include Odisha, okay, that is Orissa 36%, Chhattisgarh 12%, Jharkhand 9%, Madhya Pradesh 9% and Maharashtra 5%. So mainly if you see the North India, it was mostly affected. So even now COVID is mostly affected in Maharashtra, right? I think it is exceeding 40,000 of cases. So evolution of malarial control in India. So what brought, evolution means what brought into the existence, or what was the need of this program. So in 1946, India started using DDT. So they used DDT to kill the mosquitoes, eradicate, in order to eradicate malaria. 1953, you see National Malarial Control Program was given. 58 again, eradication program was there. 59, vector resistance detected, how to resist this vector-borne disease. And then 65, re-emergence of malaria. 71, urban malarial scheme. 77, modified plan of operation. 95, malarial action program. So in the book you can go through. 97 again, enhanced malarial control project. In 1999, national malarial eradication program. So same program you can see in a revised condition. So maybe extra points would have happened or extra initiation would have been taken. So again that has been renewed or revised. And then in the 2004 National Vector-Borne Disease Control Program, and 5 Intensified Malarial Control Program. In 6 ACT introduced in area showing chloroquine resistance in falciparum malaria. Falciparum again it is a causative organism. Then revised MVP, DCP, Drew policy, ACT introduced in high plasmodium falciparum predominant district. So main important things you can remember according to the year wise. So these are basically which led to the evolution of the malarial control program in India. So in 2013 you have bivalent introduced in the program. National drug policy for malarial cases 2014 to 15. You have newer insecticides and larvicides introduced to kill the larvae and the mosquitoes and the insects. Then you have 2017 to 22, which is in the implementation, National Strategic Plan, NSP is being implemented. So we mainly here we will be dealing when it is asked also, it is a vast portion, but when it is asked you can just give an introduction in the year why, all this and evolution of few years, recent years you can add, and then we will see the other things. Okay, so National Malarial Control Program. So at the time of independence, okay, that is 1947, during that time there were an estimated 75 million cases of malaria and 0.8 million deaths due to malaria were being reported annually. So we get to know that during independence that time, so there were 75 million cases which was detected, and there were a lot of almost 0.8 million of deaths which happened because of malaria. Government of India launched National Malarial Control Program, which is the NMCP in 1953. So that is already given there, right, in the list we have seen. Okay, so then in 1953, that was after independence, so many were dying. So in the year 1953 is when Indian government, they launched a program which is called as National Control Malarial Program, NMCP, and the first program which started in the year is 1953. Then talking about objectives. So what are the objectives? So to bring down malarial transmission, spread, and to hold on malarial transmission at low level. First to bring down, and it should happen at the lowest level. So these were the two objectives. So what are the strategies under NMCP? Residual insecticidal spray was being done with DTT twice a year. So they use the spray with DTT twice a year, it was done. Then malarial control teams to survey and monitor incidents. So that we know, right? So how you go. I think even during your community posting you had been to see how many infected cases of dengue were there, right? So like that, doing a survey and finding out how many are infected with malaria. Okay, and then no organized chemotherapy but made available on demand. So on demand the patients were treated. Okay, so these are the main strategy under NMCP. So what is NMCP? National Malarial Control Program. And malarial control activities. So what were the various activities that they were involved in? We will see that. So mainly the medical officer, PHC should be well trained and taken keen interest in malarial control activities. So in all these cases, community becomes very active. That is, a primary health center becomes very active with the doctors and the nurses there. Okay, so so they should take a upper hand, and they should make sure that they have well trained staffs. And then to fulfill the duties under the primary health center, he should carry out the following activities. So what are the various activities that has to be carried out? Early diagnosis and complete, prompt and effective treatment. So first survey and then early diagnosis, then integrated vector control. So how are we going to maintain vector control? Environmental hygiene, health education to the people. Okay, and proper disposable of the sewage, no stagnation of water. All these are few things which can be followed in the community. So integrated, everybody should do it all together, and then supportive supervision will be their plan for IEC. Okay, so that is the education, communication that is given. Recording and reporting, cross-checking of activities from records, checking random samples of blood smears. Okay, so health education, communication has to be given. IEC in detail you have studied in CET. Various mass media, okay, you can use, and detailed education to the and through the education we will be able to communicate with the people. You have to record and report, and then cross check from the records how many are infected case, how many are recovered, how many deaths have occurred, and then random sampling of the blood can be done. So these are the various activities that was involved in malarial control activities. Next, going into achievements. So when we see achievements, so what happened? We are going to see how much this program was beneficial. In the year 1953, decline in incidence from 79 million to only 2 million in 1958. So when this was implemented, almost we get to see that from 75 million cases, it became 2 million cases, and that is an excellent achievement, I believe. And then population of 165.57 million covered in 5 years from 1953 to 1958. So exactly they couldn't cover all the population, but still they were able to cover about 165.57 million in 5 years. Then reduction achieved in child spleen rate, okay, so 75%, child parasite rate 79%, infant parasite rate 63%. So much achievement had happened that the rate had come down. Okay, so they had achieved about child spleen rate 73%, parasite rate 79%, and infant parasite rate 63%. So this is about our first program under anti-malarial program. Okay, so we have seen what it is, and then objectives, what are the strategy, and then control activities, what are their achievements. Next we will go to National Malarial Eradication Program, which was started in the year 1958. So we will be seeing what are the various malarial program that has been undertaken by the Indian government and what are their achievements. Okay, so we will be dealing one by one. So here we see objective, obviously it's the same, to eradicate malaria from India in 7 to 9 years. So they wanted to eradicate within 7 to 9 years. Then what are the activities? Again, spraying, fortnightly active case detection, 2 weeks. Fortnight is 2 weeks they will be detecting the cases, then radical treatment were given, then investigation of positive cases and remedial measures were given. Okay, then achievements, what were the achievements? Lowest ever incidence of 0.1 million cases in 1965. 1965 they found that the cases dropped, from 2 million it became 0.1 million, then no more reported deaths due to malaria. So what were the phases that is given in the diagram? Preparatory phase, attack phase, consolidation phase, maintenance phase. So in preparatory you have limited survey, planning of project, preliminary operation. So that's how they prepare, right? How are they going to detect? Then attack phase, residual insecticidal. So they give the spray and then introduction of surveillance. Then where all it is, more of the cases. So there they made sure that they went and like red zone. Now right? Red zone, you have green zone. So yeah, so under like that, under our surveillance, whichever infected area, they made sure that they went and sprayed. And then consolidation phase, survival operation, focal spray, epidemiological investigations were further carried out. And then maintenance phase, area handed over to general health services. So in order to take care of the areas, in order to provide treatment. Okay, then coming on to urban malarial scheme, the proposal of urban malarial scheme was sanctioned in 1971 when it was realized that urban malaria was a significant problem, and if effective anti-larval measures were not undertaken in urban area. So mainly they focused on urban areas. Okay, that was a scheme that was developed in 1971. So they realized that urban malaria was a significant problem, and if effective anti-larval measures were not taken in urban areas, the proliferation of malarial cases from urban to rural might occur in a bigger way. So they thought that if urban areas are ignored, okay, it can lead to wider spread of this malaria. Okay, so anti-larval measures, so killing the mosquitoes even before it starts breeding and spreading the disease. Okay, so it can lead to proliferation, that is a multiplication. So in this scheme, all the towns having more than 40,000 population and showing more than 2 API, that is annual parasitic incidents in last 3 years to be covered. That time 131 towns, cities in 19 states and union territories were under UMS. So they started concentrating on urban areas. So more than, so whichever we would call urban, like whenever town had more than 40,000 of population and 2 annual parasitic incidents, if there is an outbreak, they concentrated there and they started, last 3 years are to be covered. Okay, then so totally 131 towns and cities, and then 19 states were also involved with the union territory, okay, under this scheme. So what is the objective of this scheme? That is UMS, to prevent death due to malaria, to reduce in transmission and morbidity rate. So it should not spread from person to person, and then decrease the disease rate. Okay, norms, what are the norms? The town should have minimum population of 50,000. So it is said it is above 40, so here they have stated that it should be at least of 50,000, then API should be 2 or above. 2 incidents, okay, or above, then the town should strictly implement the civic bylaws to prevent, eliminate domestic and peri-domestic breeding places. So they should make sure that all these breeding places should be strictly prevented. So like how we are taking care now. So lockdown. So like that, people have to be protected from any kind of domestic breeding places.